Greetings, everyone. This is Eric Glazer. Welcome to our live recording of the Bright Spots in Healthcare podcast produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also, most importantly, unearth bright spots, successes at health plans, healthcare systems, hospitals, and other healthcare organizations across the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on today's episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. If you have not yet subscribed to Bright Spots in Healthcare, what are you waiting for? Please do so. And if you're already on there, please rate and provide us some comments. This is the best way for us to be more easily found by other healthcare professionals through their favorite podcast app, and allows us to provide this great content to more and more folks and make more of an impact in the industry. Our topic today is super important. What winter means for the COVID-19 crisis. And I know this is important, not just for folks in healthcare, but for everyone in the world. So if you are listening to us for the first time, thank you for joining us and welcome. We chose this topic in part because of our regulars who provide us feedback. And we get that feedback and capture the voice of the customer or the attendee, I should say, via our feedback form that we send out about 45 minutes into the show. So expect that email from me at 2:45. It's a multiple choice survey. It's painless. We've asked a couple of new questions this week, and it'll provide us important information as we plan our programming schedule for 2021. We are able to provide you all this programming each and every week, or 3 times maybe a month, through all the incredible support we receive from you, from attending. Now, we know we don't charge to attend these things, but your support and participation enables us to handpick specific companies who both support our show and add to the robustness of our discussion. We are excited to announce a new sponsor. We call them partners to Bright Spots in Healthcare. The organization is called Knowledge to Practice, and they are sponsoring today's episode. They're known as K2P, and they're an innovative and what I would call bright spot in our industry, as they are providing personalized provider education and have created a really interesting new digital platform that personalizes learning based upon a practitioner's current knowledge and their attention span. The platform enables practicing physicians, hospitals, and healthcare systems to do a better job engaging physicians and providing better patient care. I will tell you more about them later on in the episode. Super exciting show. First, we have this rock star physician panel, and I encourage you to Google these guys. They are all well accomplished, awesome. If you have registered for today's live recording, to save time, we emailed you all their impressive bios, and we have had them on our website, sharedpurposeconnect.com. We will also post them to the chat right now. You could check them out and get a sense of the incredible knowledge you're about to tap into. That reminds me, we have a Q&A module at the bottom of your screen. I have a big screen here. It's not that big. I have a screen here that allows me to look at the Q&A module. I'll be looking at it throughout the show and take your questions and throw them out to our panel as appropriate. So please use that to communicate with us. Don't ask questions via the chat, please. It's just hard for us to follow everything in that way. Also, for the first time ever, we have a co-moderator for today's show. He has been a guest on our show a number of times. He's golfed with me once. He is everyone's favorite Alabamaite in New York City. He's an internist at NYU Langone, and he's the CEO and co-founder of Roster Health, who is reinventing the role of the community health worker. You actually could check them out at rosterhealth.com. They're a cool organization. He is the one and only Dr. Harry Sag. Are you ready for this, Harry?
I am. I'm not sure if I'm here to call balls and strikes in case our physician panel has disagreements, or if it's to babysit you, Eric. But regardless, it's great to be here and excited for this conversation, which is clearly very timely and near and dear to me.
I'm super excited to have you here, and I'll be able to sort of relax and let you do a lot of the heavy lifting. By the way, big weekend coming up for Harry. He is a graduate of the University of Georgia, at least undergrad. His entire family is a big Alabama Crimson Tide fan, including his father, who is a guest on our show today. So we basically should have called the show The SAG Family today, or the SAGs. That could be the name of the podcast. But before we introduce your dad, Harry, let's get serious here. We have a serious topic, and let's set the stage for our panel today. And let me have you jump right in and go for it.
Yeah, so obviously it's been about 6 months since I think we had the last COVID-19 panel that myself and Dr. Katz were a part of, and obviously a lot's changed since then, but COVID is, we all know, unfortunately, is still as timely and relevant as ever and is evolving, quite frankly, every day. We know that states such as California now are actually averaging more new cases per day today than they were during the initial surges, and unfortunately, I think across a lot of parts of the country, we are starting to see these upticks, and I think it's never a better time than now with winter approaching to be able to hear from our panelists on what to expect as winter approaches.
Great. And so, Michael, I'm going to start with you. We'll just stick with the family for now. So Michael Sag, if you have not seen him on television or heard of him, he's the Associate Dean for Global Health and Director at University of Alabama, Birmingham Center for AIDS Research. He's a professor of medicine at the University of Alabama, Birmingham. And I alluded to it, you see him regularly on the major networks and C-SPAN throughout the pandemic. So, Mike, how has your role at UAB evolved during this pandemic?
Well, thanks for having me on, Eric. The role has evolved from, first off, I was a patient back in March, but mostly at home. I didn't have to go to the hospital. But as I recovered, I got involved in the COVID outpatient clinic. So we're seeing folks who are sick, but not sick enough yet to be in the hospital, and trying to manage them, get them through the symptoms. Another really interesting thing that I participated in was a college, all Alabama colleges getting back to school. So there are 59 colleges and universities in the state of Alabama. And in a 6-week period of time, we set up an entire testing platform, ability to reach every student, a ability to test them, get the samples from 13 different sites within the state of Alabama, get them back to UAB to have the test run, of 24 to 48 hour turnaround on the test results, and then the informatics to report them back to the student, the university, and the state health department. In addition, bringing in those who are from out of state and having a way of testing them before they return to campus. That is now segued into a sentinel testing program where we're monitoring now about 44 colleges and universities in the state. So it's been a heavy lift, but really interesting project.
I'd like to know what's getting heated up in that microwave. I don't know what it is, but it sounds good. Just a quick reminder, everyone, Q&A module. You can throw questions to Harry and the rest of the panel, bottom of your Zoom screen.
So I want to turn back to Greg. Greg, we were on about 6 months ago in April, and obviously a lot has changed on the treatment front. You obviously were taking care of ICU patients. I was taking care of floor patients. But certainly our treatments have changed. Our knowledge has changed. Curious if you could kind of update us on, what are the new treatments that have evolved since April? We know that, we know back in April, 80% of intubated patients were dying. Has that number improved? And can you just give the audience an update on, now 6 months later, what's changed on the treatment front?
And first, Greg, before you go, sorry, those of you who are just meeting Greg for the first time, he's a cardiologist at Hudson Valley Heart Center, which is part of Vassar Brothers Medical Center out in Poughkeepsie.
So, yeah, we've gotten so much better in treating patients who have COVID. Harry, you had mentioned the huge numbers that were dying once they were intubated, and asked if that had gotten better. Well, not only has it gotten better, but we're not intubating all of those patients anymore. And so I think that what we've learned as far as treating COVID can sort of be broken up into two realms. One realm is the sort of supportive care, where we've learned that the longer you avoid putting these patients on a ventilator, the better they're going to do. And on the therapeutics front, we've learned that steroid treatment with dexamethasone has a really profound life-saving benefit in these patients. We've learned that remdesivir has a small benefit in potentially keeping patients or getting patients better a little bit faster than they would otherwise. And then there are a lot of ongoing clinical trials with regards to blood thinners, convalescent plasma, and other specific therapeutics that show a lot of promise, even though we haven't demonstrated that a ton of these medicines or interventions have significant benefit in these patients. But the short answer to your question is no, not as many people are dying once they get critically ill, and we know a lot more about how to take care of them than we used to.
I just
Yeah.
got to grab, Harry, I'm going to grab a question from the audience here for Greg. Michael asks, what justifies innovation during the crisis, and has this not opened the door for trial and error approach?
So awesome question, and I think the tension between clinical trialists and doctors on the ground has really been one of the major things that we've struggled with during the pandemic. There's always going to be a conflict in medicine between try first versus trial first. And it's very, very easy to stand in the background when there's no clinical evidence about a specific treatment and think to yourself, well, if those doctors on the ground would just wait until we had good clinical trial evidence before throwing the kitchen sink at their patients, we'd know a lot more about how to treat this disease. But the converse of that is when you are in front of a patient who is doing poorly, despite every single intervention that you have to offer them, there's this therapeutic helplessness that comes in and a desire to help get someone better. And so it's very, very real, this conflict. And there's no perfect right way to handle it. But I think that doctors at the bedside need to be very regimented in our thinking and to allow for the evidence-based medicine to influence the way that we practice. But at the same time, we can't be so dogmatic about sitting in our academic ivory tower. And I think it's very easy to criticize doctors on the ground when, having been there myself on the front lines, it's just much harder than it looks. Like, as Mike Tyson once said, everyone has a plan until they get punched in the mouth. And I think the pandemic is really a good visceral demonstration of that for a lot of us.
I'm going to
Absolutely agree.
Sorry, Harry, I cut you off.
No, go ahead.
Okay. Just another PSA, Q&A module for the questions. Please avoid using chat. Throw them in the Q&A module, just easier for us to manage. So Ofole, I want to bring you into the conversation, and also, Mike, I'll bring you back in, sort of our infectious disease team here. So Ofole Mbako, he is an infectious disease physician and researcher at Columbia University Irving Medical Center up in Harlem, New York. So he's got a really interesting and unique perspective on things. I want to talk a little bit about immunity here, because we know, like, unlike measles, which typically confers lifelong immunity after infection or vaccination, scientists right now aren't expecting that kind of that kind of immunity as it relates to coronavirus. Sorry. So I want to get a perspective of why that is, and also talk about how you think vaccines are in fact going to impact us in Q4 moving into Q1. I'm just going to quote, I've got a quote here from Mike's buddy, Dr. Anthony Fauci here, that says, "There are now about 8 or 9 cases of reinfection that have been reported. The protection doesn't last decades and decades. It lasts more like many months to a year or two." So, Ofole, I'll start with you, and then Mike, you could jump on top of that.
Yeah, sure. Thank you. It's great to be with you. So yeah, I think we're still really learning a lot about how immunity works with this virus. And you know, what we're getting a sense of now, 9 months or so into the pandemic, is that you know, immunity can wane and does wane in many cases. I think 4 or 5 months is pretty much what, you know, there's a consensus around right now. And like you said, there's a lot of concern about reinfection. There was, I think, the first published case out in the Lancet, a patient in Nevada who, as a 25-year-old, had a case of COVID in April, got better the next month, and then in June got reinfected. And basically, they looked at the viruses that he was infected with, did genetic testing to ensure that there were 2 genetically different viruses. And the second time he got infected got a lot worse. And so this is a concern. I think the implications for the vaccine is that you know, you'll need a booster at some point. But I think it's important to remember that it's, you know, and I've heard this a few times, it's not just vaccine, it's vaccination, right? And then that gets into how our communities, how our patients are viewing the vaccine, how much they trust the vaccine, and whether the rollout and the implementation is effective.
Yeah,
Mike?
yeah. Let me add to that. I agree with all of what Afolabi said. The bottom line is, if we go back to basics, coronaviruses in general do not have lifelong immunity. That's just not what they do. So you can get the common cold a couple times, more than a couple times. This virus appears to have an immunity that lasts about 4 to 6 months. But what we don't know are what are the exact correlates of immunity that confer protection. Everyone's assuming it's the antibody to the spike protein. That's what they're looking at in the phase 1-2 studies, and the numbers are pretty high as far as neutralizing antibody. But is that going to work in terms of protection? But a bigger picture that you hear coming out of a lot of quarters in the political fronts is the notion of herd immunity. And some people have said, well, just let it go, just let the infection take its course. And when you get about 2/3 of the population infected, will be golden. We can move on from there. But here's a problem. Number one, that immunity may only last 4 to 6 months. But worse, in the United States, if we have 340 million people, we're going to have about 230 million become infected for that herd immunity to catch on. And that would lead to roughly about 6 to 7 million deaths based on the ratios we're seeing now. That's unacceptable. I think all of us would agree. And for a vaccine, that's really where we usually talk about herd immunity, is when we develop a vaccine that is protective. But in the case of this vaccine, like I mentioned, we don't know what the correlates of immunity are. We hope it's protective. We probably won't know that until the earliest, the first part of 2021, if it's a home run. And if it's not protecting greatly, then we will see those studies extending into the summer of next year. And the final point is that those doses are going to probably have to be given every 6 months to a year to maintain the immunity. It's doable, but we've got a pretty heavy lift here.
I got a question from Tim, who says, my wife and I are 6 weeks into the Pfizer phase 3 trial. Which vaccine, in your opinion, is most likely to clear the phase 3 trial first? Do you have any insight?
I have no idea. I mean, so the Pfizer and the Moderna is an mRNA vaccine. It's never been used before for any vaccination program. So it's really cutting edge. It gets back to what Greg said earlier about innovation and cutting edge. This is very cutting edge. We've never seen a vaccine using mRNA before. Does it work? We'll find out. So I'm grateful to you guys for participating in the studies, because that's the only way we're going to know. But that will come out. Whether it's, for example, a more live modified vaccine like AstraZeneca, that might be effective, but there may be side effects with that we don't know about. We just have to wait and see.
I just want to follow as someone also who had the virus back in March, and I'm participating in a research trial following antibody levels, where I go and have my blood checked every month, starting on day 0 when I was infected, and then each month go back and have antibodies checked. My antibodies became undetectable about 4 months later. So right in that timeline that was suggested. And to everyone's point, whether there are lingering memory B cells, memory T cells that may or may not confer some amount of immunity over someone who's been uninfected is unknown. But certainly for me, and my advice to everyone who has been infected is your antibodies will most likely wane over time, probably again to months to year. And certainly to continue, I wouldn't change your behavior based on the fact that you've been infected once. I would continue doing all the reasonable things to help reduce your chance of getting it and transmission. Speaking of transmission, I want to move to that next, because I think that's such an important topic here. And one of the most frustrating and difficult parts of this virus is that transmission isn't just of those folks who are symptomatic. Boy, wouldn't that make our lives easy if only folks who were actively hacking and coughing and sneezing and notably sick were the folks who could be vectors or transmitters of the disease. But unfortunately, we know 40, 50% of folks who are infected and out transmitting the disease have no symptoms at all. So I want to pose the question to all 3 of our panelists around what are we learning about the difference between a person who is asymptomatic and one who gets sick in terms of infectious risk, in terms of transmission risk, and where your thoughts are on that. I guess we'll start with Mike and work down in age to Greg and then Afolabi.
Well, let's start with the biology again. So we know that the virus enters into the host, the human host, through the ACE2 receptors, which line the respiratory epithelial tract. And then once it gets in, it replicates like most viruses do, and then elicits an immune response. It's really that immune response that is really causing most of the symptoms. And in fact, that's what happens with most infectious diseases. It's not necessarily the bacteria, but it's a reaction to either one of its toxins or the immune response to the pathogen itself that leads to symptoms. So there are a large number of people who do get infected and remain asymptomatic. Coach Nick Saban is one of those apparently right now. We hope he doesn't get symptoms, but the take-home point is once somebody gets infected and they start spewing virus into the environment around them, that's how transmission happens. Another key concerning thing about this virus is even in the symptomatic patients, the peak time of transmissibility is in the 8 to 24-hour period before the symptoms develop. So somebody could be out at a party or something, they feel great, next day they get sick. That night before when they were at the party, they're spewing out lots of virus and they in essence become a super spreader. So that's the type of thing that makes this very difficult and tells us that we need to keep our guard up at all times.
So to sort of piggyback on that, the question of, well, what do we do as a society to reduce spread, and how do we look at sort of risk stratifying the different individuals who may be spreading, really boils down to the fact that 80% of the virus or more of the spread that we're seeing is related to these so-called super spreader events, which are enclosed spaces with lots of people densely packed together in situations with poor ventilation. And part of, I think, the way that we're all needing to alter our lives is to not just think about what we're doing for ourselves to protect ourselves, but also how we're protecting society and how we're sort of doing our part. And so I think that if you're interpreting the idea that the bulk of spread is really driven by a small number of interactions that people are having, that a huge part of any one individual mitigating that spread is to try to minimize the large, densely packed social gatherings that we're having. And whether that means parties or in-person meetings, or especially I think indoor dining is a real concern that we should all be having. We should be thinking about what are the small minority of things that we would be doing in our lives that provide the bulk of the public health risk, and trying to, I think, minimize that both for our own benefit as well as for society's benefit.
Yeah, I completely agree with that. I'll just add, that kind of the way I think about it is, there's how much of the virus itself you're exposed to, and then yourself as the host and your own kind of immunity and your ability to fight against it. And so, just adding on to what Greg said, we now know that duration of exposure, right, and then how much virus you're exposed to, the inoculum, we call it, really does have an effect on how sick that you can get. So that's why it's so important to protect our essential workers or frontline workers, the people who, have to be, whether you're a grocery store worker, whatever it is, a bus driver, that you have to be in enclosed spaces with other people for a prolonged period of time. And then there's some interesting studies we've learned more about kind of the differences in immunity and why some people get more sick than others. I think blood type has been something that has come up a bunch, and there's been some retrospective studies, particularly at blood type O as being protective in certain cases for patients. And then there's also a molecule which is part of our innate defense system called type 1 interferon. And people who have a severe deficiency in this, either a genetic deficiency that they're kind of born with, or an acquired deficiency, get very sick and then have virus for a long period of time and have trouble clearing it. So we're getting good sense over time why there are such differences, and hopefully that can help us figure out who we need to really protect.
So guys, we actually, for the non-clinicians in the audience and yours truly, we know our blood types, at least most of us do. What's the information that maybe you could share or expand upon around blood types and how that's affected? Blood type O, how do we know that there's a chance that blood type O folks, not that I'm blood type O, I am, are maybe subjects to less symptoms?
Yeah, so these are retrospective studies that they do. So they basically look at a large group of patients who have been infected over the past few months, and they look at their outcomes, right? They look at the people who have died, the people that have needed to go to the ICU, and then they look at the people who have had milder cases. And when they look at that, they stratify by blood type. And I think a recent study came out in one of the hematology journals, and it was almost 2 times as likely to progress to severe disease if you have a blood type A or type AB. Versus blood type O, right? So when they compare the 2 groups, blood type O seemed to, be more milder cases majority of the time. So we don't know the implications of that. I mean, that's just kind of correlation, not necessarily causation, but certainly we're just looking for whatever factors that we can find that could be protective.
Yeah, and I'd like to add one thing to that. What Afoli just described was a relative risk of about 2-fold. It's not an absolute absence of risk. And I've seen people on Twitter and other places saying, oh, I'm blood type O, I don't have to worry about COVID. Wrong. That's not true. It's just saying relatively speaking. And another thing, we can't change our blood type. So we are what we are. And if you're type O, you can feel a little bit better. If you get it, you might not get as sick, but you're not 100% immune by any stretch. And you still could die even if you have blood type O.
Harry, I think I just experienced something you probably your whole life, because I think he was talking to me with my blood type O, and he was just giving me a quick little lecture.
Yeah.
A couple of quick follow-up questions that I want to combine from our audience. So I'm going to combine them in 2, and I'll lob it out to you first, Mike, and then if anyone wants to jump in, let's do it. Given the range of concerns that you raise, and putting politics aside, that's not my words, that's the Tom's who's asking the question. What should my personal plan be for avoiding and dealing with COVID-19, and what would your recommendations for public health be prior to a vaccine? And then the follow-up from another anonymous attendee is, how safe is air travel? I don't hear about people catching the virus while traveling anymore.
Well, the good news is it's pretty simple what we can do. You've heard it. It's like a mantra by now. Stay at home when you can. When you do go out, wear a mask. Avoid large crowds. Avoid any contact with people who are not wearing a mask because they could be spewing a lot more virus. And wash your hands frequently. Those are the things we know to do. Okay. And if you're going to be around people, better outdoors than indoors. But as this topic is about autumn, we're headed towards indoor season. And oh, by the way, influenza is going to be lurking as well. The other thing about air travel is that air travel probably is a lot safer than we used to think because of the airflow, up to 30 air exchanges an hour on the plane. So, and fresh air coming in, HEPA filters, better than most indoor environments, but we're packed together. And I'd prefer airlines that separate people out and require masks.
What I would kind of add to what Dr. Sag was saying is that there's no one perfect intervention. That's why you hear this laundry list from all of the public health experts of wear a mask, wash your hands, avoid big indoor gatherings. And so since there's no perfect intervention, the best way to minimize your own personal risk and also thus minimize the public health risk is to try to do a little bit of everything. And from my own perspective, what I counsel my patients on is trying to figure out a little bit about your own personal health status, meaning what likelihood do you have of having severe illness? And what that's based on is your age, your medical risk factors, which really include the cluster of high blood pressure, diabetes, heart disease, the things associated with metabolic syndrome, abdominal obesity, big waist size. And those are the patients or the people who are at the highest risk. And if you're in that group, the level of concern that you need to have should be much higher. And that goes double for having any of those risk factors plus advanced age. And when I say advanced age, there's a gradation with how old you are. Older is at higher risk. I sort of think of an inflection point probably in the 60 to 70 range, where those older than that are probably quite a bit at more risk, and those younger have diminished risk. But from the action perspective, we want to really focus on minimizing the opportunities where we're going to be in close proximity to lots of individuals in an enclosed space with poor ventilation. And if you focus on which people are at the highest risk, and which activities put us at the highest risk. That helps you sort of risk stratify in your own mind what your tolerance is for all kinds of different activities in your day-to-day life. I think that mask wearing is something that, for reasons that are probably not worth going into, has become sort of like a political symbol and a sign of a lot of things that don't really have much to do with public health impact. But wearing a mask is a big deal. And there's a reason that doctors are always wearing masks, and we're not, and very few of us are getting sick. And so we wouldn't be doing it if we thought it was stupid. So you can sort of look at the fact that almost all doctors are wearing masks. And if we're doing that, it's not as a method of virtue signaling. It's because we believe in it and we're putting our money where our mouth is.
Yeah, would you want a surgeon operating on you without wearing a mask? Well, it's the same kind of thing out in the environment. You're protecting the people around you from becoming infected. It's a courtesy and it's a public health issue.
Do masks protect from aerosols?
It depends what type of mask. So, you know, there's been a lot of discussion about the difference between an N95 mask, right, which is fitted to, you know, us as health workers. We actually have to go in and get our faces measured and things like that to make sure it fits to our face. And we haven't done that this time because we needed to skip that step. But that's the most protective. And then you have the surgical masks, which provide less protection. And then some of these just kind of at-home kind of coverings, I think those are the least effective. So I don't know if it's a yes or no, but I would think about it kind of in gradations like that. And just to challenge the premise to the first question, you know, I think a lot of people use this phrasing, right? Like, I don't want to get political, or I'm not trying to get into politics, but I think what we've learned is that we can't avoid politics. Medicine is political. Public health is political. And as we continue to say, let's avoid this, people continue to suffer. So, you know, what I would encourage is people to openly talk about the politics, but make it be a politics of reason, a politics of hope, a politics where we speak about prisoners, people working in meatpacking plants. We talk about people living in nursing homes. We talk about the homeless, right? So that we just don't have a policy that says everybody stay home when people don't have a home, when people are in positions where they're having to work to support the community running. So I think we have to kind of think about how we engage in a politics that's saving lives instead of trying to avoid politics altogether.
Nicely said. And we're going to get a little bit into sort of the different social determinants later on in the show. Also, another PSA, those of you who are regulars know that I'm pretty good at stopping at the zeros right on time. I'm going to tell you we're probably going to go a few minutes long here, and this group in front of you has been generous enough with their time to stay a little bit late. So if you have a meeting at 3 and you really want to stay on, change it now. We're going to go a few minutes late. So I want to talk about sort of hospitals and health systems, and what do we anticipate now to be the greatest challenges for these organizations as we think back to what we've been going through since March and April, and then we're looking out 6 months. I guess the way I want to phrase it is, when we think about 6 months from now, in April of 2021, we're all sitting here after the winter, you know, what is your best guess to what you wish you'd tell yourself today, and, you know, that we would have learned by then? So let's look into the future and anticipate what's going to go right and what's going to go wrong. And I know, Harry, you have an opinion on this, so I'm actually going to turn you into a temporary panelist and bring you into this question first.
Sure. So I'd be thinking a lot about staffing. And really, when I say staffing, I'm thinking about that in 3 ways as a really challenge going into the winter. The first challenge is on having the appropriate level of staffing. As we all know, for those who work in hospitals or have to think about staffing for hospitals, having the right number of physicians, nurses, respiratory therapists, environmental services, et cetera, level loading that in the uncertainty of not knowing exactly what your census of COVID numbers are going to be, elective surgery numbers, et cetera, can be a real challenge. And I think having systems in place and being thoughtful right now to be prepared for contingency plans or having a way to have a flexible staffing model, I think is really important. The second thing to think about staffing, though, is staff are people too, in the sense that they're going to get exposed. They're going to get exposed, whether they're exposed in the hospital, they're exposed at home, they're exposed in the community. and thinking about those contingency plans and having robust, how do we bring people back to work if they've had an exposure? How do we bring people back to work if they do become infected? And then being willing to realize that what we'll say today may need to change or evolve in 1 month or 2 months and 3 months, getting back to how much we've learned in the past 6 months. And then the third element around staffing that would be top of mind for me is on the concept of burnout, and the idea that, if you think it's hard in the general public, to the impact of COVID's had on your life, for those that are in there every day, taking care of COVID-19 in the ICUs or in the hospitals, the grind is very real. And obviously it's only, 6 months in now, and I think provider burnout's already being seen in many places. And I do worry, or I'd be thinking about, if I was, in a hospital, thinking about my staff, about how I'm going to manage and mitigate that over the winter, if and when numbers do increase.
Anyone else want to add to that, to that answer and that dialogue? It doesn't have to be about physician burnout specifically, but just what are going to be our greatest challenges and what we're going to learn.
Yeah, I mean, I think, where I work at Columbia, we have 2 hospitals. We have the main hospital, which is in Upper Manhattan in Washington Heights, and then another more community hospital, which is a little further uptown, called the Allen Hospital. And it's a predominantly Dominican community, predominantly Latinx community, an African-American community. And the Allen is a smaller hospital, so it was really being overwhelmed when we were in the middle of our peak. I was talking to a good friend of mine who was the chief quality officer there, Dr. Derek Mazik, and he basically led a team that stood up a new hospital on the adjacent soccer field. And there were ventilators, there were beds, pretty much a fully staffed hospital, just because the actual hospital didn't have the space and capacity. And that structure still stands. So when I go to do my consults there, I still see this big structure on the soccer field near the hospital in anticipation of another wave. So all that to say, I really hope, months from now, we look back and we realize that we were really creative and innovative in our solutions, and we kind of broke down these barriers that really kind of propagate suffering. In New York City, there's this separation, right, between the private health system and the public health system. And some of our hospitals in the public health system were really overwhelmed, and some of our private hospitals had space, right? So there shouldn't be this system where only public patients should go to public hospitals and private to private. And we had, I think, the military ship come in, and no one was going there for some reason for a period of time. So I just hope 6 months from now, looking back, we realize, like, we can be creative, we can be innovative, and that would have saved many lives for people to get care.
I would say, I hope we look back 6 months from now and think we really overreacted in our plans for what the winter was going to be like. And in a pandemic, if you, in retrospect, feel as though you overreacted and overprepared, it means that you probably did the right thing. And if we think as a society about what do we want to be the legacy of what we learned from this pandemic, I think one of the striking things is how the people who were most vulnerable are the ones who suffered the most during the pandemic. And the idea of not being worried about COVID is the ultimate reflection of privilege. It's like the privilege, that you're healthy to begin with, that you can miss a few days of work and not worry about losing your hourly job, that if you get sick enough to require hospitalization, that you'll be taken care of by doctors who are not overstaffed and overwhelmed and overworked, and that you're not going to be bankrupted by medical bills at the end of this. And so, the pandemic sucks, and it's miserable for so many of us for so many different reasons. It is emotionally, physically, just exhausting. But if you think about who is suffering the most, it's not the people on this webinar. It's the people who are working hourly jobs and don't have health insurance and are struggling to kind of keep society together. And so I hope we look back in 6 months and say, this was a winter, like the winter was a lot better than I thought it was, because it will have meant that we will have avoided a lot of unnecessary deaths and unnecessary suffering.
That's a great point. It's a great point, Greg. And I'm gonna say let's hope we can say that in 6 months in April at this next one, at our next one, or our 6-month COVID update then. I want to transition a little bit on the spirit of how much we learn, how much what we know about the virus changes, sometimes, day to day, much less week to week or month to month. And certainly, again, knowing what we know now as compared to 6 months ago and even, a month ago, how things changes. Obviously, for myself, yes, I still see patients part-time, but I'm out, trying to run roster as well. So it's hard enough for me to stay up to date always on what's the latest and greatest as new information's coming out daily. A question for a couple of our panelists, maybe we'll start with Greg and then go to Mike. What are you doing to stay up to date as information is coming out almost daily in terms of whether it's treatment or transmission or about the virus? What are your sources you go to? What are your strategies so that you can stay current and up to date?
So there is a constant fire hose of new COVID information that I think we're all drinking from. It's like anything else. Read all the time, think critically about what you read, and as much as you can, go to the primary source instead of just reading someone else's interpretation and letting them do the thinking for you. But the answer to how to keep up is it's impossible to keep up, and you do the best that you can to not drown in the onslaught of new information.
Yeah, there's an adage that I learned in training that there's a thin line difference between what's dogma and what's dog manure. And this changes in our careers, but in this epidemic, it changes almost day to day. And keeping up with that is extraordinarily difficult. What I do is I will scan the literature almost every day. One of the reasons I'm an editor for the Sanford Guide, and so I want to make sure, and I edit that page along with a couple of other folks, and I want to make sure that that's up to date. And that's free to everyone, by the way, so if you can get on that if you'd like. But the other things is a couple of websites that I'd suggest. One is one called 91DVOC, which is COVID-19 spelled backwards. And it has all the epidemiology from countries and states, and you can break it down a lot of different ways. And that's a good way to keep up with what's happening in the epidemic. So you see the United States surging again right now with a number of counties, states, as we saw rising, and we talked about earlier. The other thing is a lot of frequent questions I get are, can I hold my wedding reception? Can I have people over? And it's really a function of relative risk based on size and where you are, size of the event and where you are. And there's a great calculator called on the Georgia Tech COVID calculator. Just type that into Google, Georgia Tech COVID calculator, and it'll bring up a map, and county by county, depending on where you are, you can see if you have a group of 10 people, 25 people, 50, 100, what the relative risk is, or what the harm, what the likelihood is of one out of that group, 1 out of 10, 1 out of 25, 1 out of 50, what the likelihood that is. So we're in my neck of the woods, if I'm putting 50 people in a room together, there's about a 92% chance that 1 out of the 50 will be infected, and you can use that.
I posted both those links to the chat, folks, if you want to grab onto those links directly and copy them. A good transfer, a good actually segue, I should say. So I did tell everyone at the audience that I wanted to tell you a little bit more about our new partner, Knowledge to Practice, and it's a perfect time to do it. So K2P, just if you have never heard of them, they provide a digital learning platform that is critical to enabling practitioners like the folks that you have in front of you to assess and maintain their core medical competencies and keep pace with emerging medicine. So, for example, they provided a platform during the COVID pandemic, right when it hit, and launched it and rolled it out to 25,000 doctors across South Carolina who were able to access it for free thanks to Blue Cross Blue Shield of South Carolina. And it provided these docs with immediate access to trusted medical information that continuously updated and continuously updates throughout the pandemic. And them and other advanced practice providers are able to keep up to date with the most current best treatment practices, which of course is so critical at a time like this. It's digital, it's mobile, it's across all multiple platforms, and they've gotten really effective at understanding the size of content to distribute or dose, if you will, to the physicians at one time. And the modules tend to be 5 to 20 minutes in length. And I mention that because if you're working at a hospital health system or either at a plan and you want to improve your physician engagement and also improve the quality of patient care and mitigate risks across a hospital healthcare system, you should look into being able to get this up-to-date information to your providers. And I think, in my opinion, the reason they're more effective than anyone out there at doing that is because of their founder, Mary Ellen Beliveau, who is a visionary in the world of continuing medical education. She was inspired by her own story when her daughter was born of congenital heart disease, and her experience helped her realize that physicians need more contemporary tools, progressive tools, enabling them to refresh their knowledge and skills while they go on this ridiculous pace that they are expected to keep. So she spent a half a decade leading specialty services at Pri-Med, which is one of the leading providers of continuing medical education. And then she moved on to become the SVP and Chief Learning Officer at a little known organization called the American College of Cardiology that Greg may know a little bit about. She's also the chair of a community hospital in the DC area, in addition to her responsibilities at K2P. They're launching a module on complex diseases in 2021 to augment their COVID content, their internal medicine content, and their cardiology content. Check them out at k2p.com. She's on LinkedIn if you want to meet her. She's on the website. I think her email is listed there as well. And if you want to meet her in 2 weeks, I'm actually hosting on October 29th, so you can mark your calendar. Actually, Sherry, why don't you throw up a poll if folks want to join us on that? So on October 29th at 2 p.m., I'm going to host a fireside chat via Zoom with Mary Ellen, as well as her medical director, Dr. Daniel Davis, and Dr. David Nash, who I know a lot of you have heard of, or at least know of. He's the founding Dean Emeritus of Jefferson College of Population Health, which is obviously a very innovative new school. He's also the professor of health policy at Jefferson Medical College. So they'll be in a panel session where you could ask them questions, and you'll learn a little bit about how to truly create an innovative system or process around physician and advanced practice provider education. And they'll be able to understand some of the more progressive approaches to capturing a busy doctor's attention by providing them useful information. So check them out, and hopefully we'll see you all on October 29th at 2 o'clock. I'll hand it over to you, Harry. Go ahead.
Great. I want to transition to a topic that is near and dear to my heart, and that is that social determinants of health and health disparities that we've touched on thus far, but dig a little further into it. I want to go to a folio on this one and hear a little bit about in New York City and in Columbia University in particular, some of the innovations around SDOH and some of the things that you all are doing to reduce the gap around access to care in Harlem, and really focus on knowing that this virus is unfortunately disproportionately affecting those that are underserved. What we're doing, at least in New York City and Columbia, to address that.
Yeah, for sure. So, I think first thing I always do is kind of step back to really understand the scope of the problem. So a statistic that's really stuck with me is that 1 in 1,000 African Americans have died from COVID. And when we look at the kind of relative rates, African Americans are over 4 times more likely to be hospitalized, over 2 times more likely to die, with similar numbers among the Latinx community, among American Indians and other people of color. So this is a national tragedy. This is a stain on our country. And the fact that this is still ongoing, this means that it's kind of an all hands on deck, right? 5-alarm fire to really make sure that we put an end to this suffering. I've been heartened by a lot of kind of activity around this in health systems throughout the country. In ours, I think it was just announced that we have a Center for Health Equity going up, which is attached to the New York Presbyterian Hospital. And for people who don't know, New York Presbyterian Hospital is comprised of both Columbia and Cornell, so a new Center for Health Justice, to really kind of think about a health disparities, health equity framework throughout our institution, throughout our clinical operations, et cetera. And I think it's that kind of very high level thinking that will be important in order to really make an impact. Simply because there are a lot of institutions that are in communities, but haven't really made great contacts with communities, have good communication with communities, understand the communities that they're in. And so I think that's where it starts. So a lot of that's percolating. I think another thing at our institution that I'm encouraged by, so there's something called the COVID Prevention Network, the COVPN. which is essentially a network of sites throughout the country that are engaged in vaccine trials, treatment trials. They're tasked with recruiting patients and really kind of getting us to a place where we know what interventions that we can roll out. So we have a clinical trials unit at Columbia, and the reason we've been able to kind of incorporate that so quickly is because there's something called an HIV prevention trials network, an HIV vaccine trials network that basically existed before this. And so using that existed infrastructure, we now brought the COVID-19 system in. And our HIV prevention trials clinical unit has done a great job reaching out to communities. We have community advisory boards who used to meet in person, but now are Zoom-based, right? And that's just not representatives from the community. I think this is important, but it's open for any interested community members who want to learn more about the issues, who want to become health advocates themselves. They're invited to join. And then we have people from the community involved in the clinical trials unit who go to fairs, who go to different events, and have done that over many years, who know their community well. And so it's good that that infrastructure is kind of being moved over now to COVID, because as we know, there's a lot of mistrust out there. And I think that mistrust has been well earned because of how much communities of color have suffered during this time. But I think it will be that on the ground work, that communication with community that will get us to a place where our vaccine trials, our treatment trials have good representation, people of color in them, which is the only way that we can really know for sure that these interventions work.
Absolutely. And I think that the concept of, using the community, knowing that the community or the folks and local community members are able to build that trust, and the trust is going to be so important, especially as we move further into vaccines and in the winter, to really influence behavior change in communities, and leveraging those trusting relationships is mission critical as well. Eric, I'll kick it over to you now.
I want to shift over to innovations. By the way, folks, your survey probably landed in your inbox. Give us a few minutes, give us some feedback, especially as it relates to if you want to hear a topic like this again in the next month or two, and certainly in 2021. And by the way, we're going to go 5 to 10 minutes long today. I mentioned that at the onset, so we are going to get at most of your questions. I see a bunch of Q&A questions in the Q&A module. We're going to get to all of them. Keep them coming. So folks, I'll start with you, Michael. What innovations are happening today that you could share with us, whether they're systemic or local at a hospital, and maybe we could inspire some sort of ideas for innovation later on. So what are some things going on in your neck of the woods?
Yeah, there's some simple things in the hospital, like when you have an ICU patient, you move a lot of the machines out into the hallway so you don't people have to gown up every time they go in to make an adjustment for hemodialysis or for even ventilator settings sometimes, depending on the setup. But there are some other really interesting things that show how the health systems have changed in response. And one of the things we haven't talked about yet are those people who have prolonged symptoms from COVID. And there's a lot of them. It's called the long haul syndrome. And those are people who have either neurologic, cardiac, pulmonary, other organ system dysfunction that lasts well beyond the usual 2 to 3 weeks of a course of illness. And these go on for sometimes weeks to months, and it's very debilitating. So people have set up clinics. I know Columbia has several of them. I know neurology in particular, because I've sent some patients there. So that's one thing. And then finally, innovative trial design. We talked about all these new therapeutics that are being developed, but how do you speed up development? And back in the days of Ebola, they created something called an adaptive clinical trial, and that's been applied to oncology, and now it's being applied to COVID. And what it is you can basically have a 5-arm study, including a control group. People who are eligible get randomized even before they agree to consent. To keep it simple, they get assigned to one of the arms, they get presented, do you want this therapy? They sign informed consent. Well, what's unique about it is that it's ongoing. It goes on every day, and as one arm either graduates or fails, then it's replaced with yet another. Right now, it's mostly in the immunomodulator space, but that's really exciting. And that's called something called an iSpy or iSpy 2 design. And I'm on a data safety monitoring board for the COVID trials. It's very exciting. It's based on Bayesian theory of using probabilities that this is going to work or it's not going to work in real time.
That's really cool. Where are there some needs for innovation, guys? I mean, we probably have a lot of healthcare technology companies and innovative companies watching right now. Where are there some needs for some progress as it relates to, that you've learned about during this crisis? I'll start with you, Afali.
Yeah, so I think, one thing that our hospital did during our spike was, patients who would come into the ER and they would either be, have mildly low oxygen or they would be mildly symptomatic, and they were right on the cusp of whether they needed to be hospitalized or not. Basically what we would do is, send them home, some of them home with actually home oxygen. And then we would have a clinic where people would be able through telemedicine to check in on them a few days later, talk to them and their families, and make a decision about whether they needed to come back into the hospital or whether they were getting better and should stay home. So I think kind of innovative uses of telemedicine and technology that allows us to stay in contact with the patients, those that don't know if they should come to the hospital or not, or we, discharge because they're right on the cusp and, we're trying to maintain space in our ERs. I think that's a big area in terms of keeping hospitals from being overwhelmed. And then I think the area of kind of education and information dissemination is important as well, right? Particularly in communities that need that the most. There are a lot of echo chambers out there. There's a lot of different sources of information. And so kind of creative ways to think about how we, in a rapidly changing information landscape, how we get out kind of true and evidence-based information to communities that need them.
That's been one of the most interesting parts of the pandemic, from just sort of like I'm watching from afar perspective, not I'm deep in it, just how wildly different some of our information echo chambers are. And I think when we get very caught up with innovation and the newest thing and the most novel therapy. And as doctors, we are very guilty of wanting to play with our shiny new toys instead of sometimes falling back on the tried and true ways of treating patients, of tracking disease spread and contact tracing, of like isolation after you're infected or quarantine when you've been exposed, of masks. And if you think about in the hospital, we got so excited about things like convalescent plasma, inhaled interferons, clot busting medications, that we started using all of these kinds of novel interventions without real regards to what the downstream effects were. And so it's important that we innovate, but it is equally important, if not more so, that we don't put the cart before the horse and make sure that before we just jump off, that there are not going to be unintended consequences of whatever innovative behaviors, treatments, public health interventions that we do that will have the treatment be worse than the disease. And so it's just very, very important in this society of instant gratification, when we all want to do better, faster for more people, that we really stop and think every once in a while about whether we should, not just whether we can.
All right, guys, we're at the top of the hour. We're going to go a little bit long here and rattle off some questions from the audience and get those answered for all of you. Go ahead, Terry.
One of the questions that I think, I'm sure a lot of folks are seeing, I see a question from Tony about, what are your thoughts on working on a public gym, and to kind of broaden that, question on what are your thoughts around, how you're personally kind of, trying to manage your own risk in terms of what you're willing to tolerate in terms of your own personal decisions. Maybe we'll go to Afoli on this one.
Yeah, it's a good question. So, I see risk as a kind of communal resource, right? And this is what kind of ties us all together. So when I think about an activity I'm going to do, or if I'm going to go out to eat in an indoor restaurant or something like that, I think about, whether that's number one, if there are people in my life that I'm in contact with who I need to really kind of make a good decision about whether that risk is even worth it or not. So for me, I don't really take that risk because I'm around family members who I want to keep in good contact with, and I don't want to expose anybody to the virus. But I think just in general, I think as a community and as a society, right, we want kids to go back to school. We want people to be able to go out and get their essential needs done. So what does that mean? That means we should probably not have people going to bars. That means that we don't, need to prioritize indoor dining if the numbers are, really kind of rising. And I think that's difficult, right? Because closing indoor dining has implications for restaurant owners and restaurant workers and the economy. But really, I think about my individual risk and whether it's worth it in terms of the people who are exposed in my life. And then I think about the communal risk. So I'm really not doing the activities that I used to do just because I don't want to be contributing to less of an opportunity for our communities to do the essential things that they need to do.
You brought up children there, so I'm going to ask a question from Ferris to the group. It'll be like a jump ball, although I guess I'll lean to you, Mike, since you're the parent of the group. What about COVID? What is COVID doing? What about COVID, and what is it doing to our children and their social skills, being lost, not seeing smiles or facial expressions, their anxieties about not trusting anything or anyone around them? By April of 2021, what should we be doing, especially with kids, to avoid COVID trauma?
It's a tough situation because it goes well beyond the medical. We know that kids get infected and they can transmit at home, and they're oftentimes asymptomatic. And we also know that kids can get desperately ill, and there's been a couple of deaths of children, but it's a rare phenomena. But beyond that, as the question implies, there's a socialization issues that are constrained because of normal activities, just going outside and playing with friends or gathering in groups, or a lot of the creative arts like dance and singing and chorale groups and even sports become relatively high risk things that start to block what we ordinarily do. And it's a tragedy. But we're in a tragic situation. We're in the middle of a pandemic that none of us have experienced before. And my personal view is if we buckle down and do the right things now and consistently, then we'll buy space and time for us to relax. And other countries have done that. We asked the question, what are we going to learn from this? Well, you look at the countries that are doing best, Korea, Japan, Taiwan, New Zealand, Australia. What's different about them and us? They went through SARS-1 in 2003, and they in essence said never again. And they were prepared for this, and they implemented their strategy. And over the summer, which is the winter months for them, there were 6 cases of influenza in New Zealand for the entire flu season. That's it, because they had done the things to reduce COVID transmission, and that spilled over into influenza. If we do that, we can get back to normal activities sooner. A vaccine is kind of a deus ex machina from Greek tragedy, where you come in and rescue the protagonist at the last minute. We can't just rely on that. We've got to do the things we know to do now.
Almost 5 million people in New Zealand, 6 cases of influenza.
It's amazing.
It's possible.
Greg, I want to come to you with a question that I think has been in the news recently since President Trump came down with COVID-19 and received a monoclonal antibody cocktail as part of his treatment. And, I don't know if we've really discussed that, but I think because folks have probably read about that, I wanted to get your thoughts on what it means in terms of what the data is showing around monoclonal antibodies. If you think that if they think at some point they will become widely available, if they would ever be seen as kind of a prep, if you will, and for those that are non-clinicians, the idea of almost using it as prophylaxis. So Greg, kind of to you on monoclonal antibodies and some thoughts.
So how about we show that monoclonal antibodies are truly effective before we decide about giving them to 300 million people as a prophylactic? Look, it is a very exciting potential treatment. You give somebody antibodies for a virus that they are going to be infected with, and theoretically, you may improve their ability to fight disease and tamp down on their immune response because the virus isn't spreading quite as strongly. But we are so far away from having proof of effectiveness, number one, that just because there's a biologic plausibility has no bearing on whether or not we'll actually show these medications or these treatments to be effective in reducing severity of COVID-19 infection. That's number one. Number two is monoclonal antibodies are really expensive. Those are medications that if you have a chronic autoimmune disease and you're on monoclonal antibodies, those are tens of thousands of dollars a year in treatment. With the cost of dexamethasone, like dollars per dose, it seems, and that has a proven mortality benefit in severe COVID infection, that we are just so, this is a great example of something that we see administered in a high profile situation. We see the person who received it gets better, and thus we extrapolate. And I'm guilty of this also, but it's the human sort of cognitive bias to see effectiveness and then assume that it's because of that medication. For all we know, the monoclonal antibodies made President Trump worse and delayed his recovery. You just don't know. And until you have a clinical trial showing effectiveness, the road to hell is paved with biologic plausibility.
And the monoclonal antibody product from Lilly, which is just like the Regeneron 2 monoclonals against spike protein, the study was just put on hold because of an adverse event. So safety we have to determine in the trials as well. So great points, Greg.
Yeah, I wanted to ask that just for the layman in the audience who kind of subscribe to I need hope kind of thing. What are some of the inherent risks of just rushing into this from a safety standpoint?
People have all kinds of reactions to different treatments. Look at some of the vaccines where there was a signal of a couple of cases of transverse myelitis, which is a neurologic disorder that can lead to essentially permanent disability if the cases are severe. Convalescent plasma treatment, for example, has all of the risks of getting a blood transfusion, infections, immune responses, extra volume and fluid overload. There is no free lunch in medicine, and it's so sort of silly of us to think that treatments for COVID are going to be any different than treatments for everything else, where there are risks and there are benefits. And the higher your level of risk, the more willing you are to take the chance of a side effect or an adverse reaction from a treatment. But it's exciting to think about the possibility of all the ways that we can potentially treat this devastating disease. But we need to not get so excited about the new innovations that we forget about the fact that bad things can happen by jumping in. This has been proven over and over and over again in the history of all kinds of medical therapies.
I just want to add something really quick to that, because I think, Greg makes really great points. And I think a lot of times we forget about the importance of things like palliative care, which isn't very, very sexy to a lot of people. But when someone comes in with a potentially deadly illness, and they have to make decisions about whether they want to be intubated or not, if it gets that severe, whether or not they want to be part of a clinical trial, etc. They need compassionate, really foot forward care. And my concern is that, it's such an emphasis on, okay, what's the magic bullet and what's the combination of medications that we can get to cure people? We're forgetting the basic parts of medicine, the basic aspects of the oaths that we take as providers, and really, what we owe to each other as citizens of this country, where we really care for one another. And when we're faced with mortality, right, that's when it's foot forward. Michael knows at the beginning of the HIV pandemic, which is still ongoing, still affecting communities of color predominantly. There's the same denialism, right? The same idea of, okay, let's not go in that room, or let's not stigmatization, around certain communities. And it's the same thing happening again, where it's just that compassionate, that palliative care allows people to face what is the most difficult moments of their lives with this novel virus. With people there for them, and not everyone, focusing on what the magic bullet is.
All right. Well, we're going to run off. Oh, go ahead, Harry. Sorry.
I know for some of our audience, maybe hearing all of this may be a bit of a downer, so to speak, in terms of no magic bullet, no easy answer. But I just want to I want to frame it a little differently, mostly to make sure that we give ourselves a little bit of hope here, in the sense that it was only 7 months ago in mid-March when the standard of care treatment at that time was hydroxychloroquine, maybe azithromycin, which obviously we now know definitely don't help, and if anything, actually hurt folks in treatment of this. And in 7 months, which again to everybody feels like an eternity since all of our lives have been upended by this, we have made tremendous progress in terms of identifying at least some therapeutics, some that Greg talked about earlier. We at least have some vaccines in phase 3 trial. I guess real quick for Mike to put this in perspective compared to other, novel viral, pathogens, just to put it in a different lens, in 7 months, I mean, how does this compare to when other viral pathogens and novel viral pathogens have come up in terms of the progress that's been made in 7 months?
Well, Afolae just alluded to it. I mean, I was involved in the early days of the AIDS epidemic, so let's look quickly. Syndrome defined in June 1981. The virus wasn't described until March of 83. A test wasn't available till May of 85. A treatment wasn't available until March of 87, right? 6 years. We're 6 months. We have the virus identified. We have it sequenced, the first vaccine, several different treatments, many more on the way, and we're only 9 months into this. Are you kidding me? This is an amazing amount of progress, and we're dealing with, sort of new world issues here when we talk about we're a little early on this, a little late. I watched people suffer for 10 years from AIDS when we had nothing. Go see the Dallas Buyers Club if you want to see desperation. That was it. And so we are making huge progress, and I'll just finish with a comment that this is all because of the science. This is because of what we did in AIDS back in the 80s and 90s is all built on that. The vaccine technology, the treatment technology, all that was developed, and we're standing on the shoulders of all the patients who volunteered for studies and the scientists who did their work back then. So there is cause for hope. We're just impatient. I get it, but it's going to take a little bit more time.
Stuff. I'm going to end with one last question. I mean, we have more than one last question, but I don't want to keep you guys beyond what you have given us. One attendee is asking, and I think it's just very relevant today, if you care for a family member, what is the best way to protect yourself? And also, once you have been exposed, how many days should you quarantine, and how long could it take before one shows symptoms? Mike, do you want to grab that first?
Well, yeah, and I'll turn over to the other two real quickly. But bottom line is, it's very common. Number one, if you have an exposure to a known positive, that positive person needs to go into isolation, and you need to go into quarantine. They go into isolation in general for 10 days. You go into quarantine for 14 days. Why? Because there's an incubation period of somewhere between 4 to 7 days when the virus will sort of set itself up, and then you start to spread the virus. There are algorithms and things about testing. I wouldn't rely on that too much. Just go with those two things. As far as somebody in the household, everybody wear a mask, isolate that individual in a room by themselves, and just try to have minimized contact. But unfortunately, 70+% of people who live with others who've had COVID ultimately pick it up. I mean, Afolae or Greg, you may want to add more to that.
I mean, wear a mask, wash your hands, don't touch your face. Think about the common stuff. I've seen a lot of temperature screenings and places, public places that are very focused on wiping down surfaces. To me, that is protective theater rather than protection. And so I think that all the things that Michael was saying are right. Wear a mask, wash your hands, don't touch your face, and it's not just about you, it's about everybody. And so that's kind of how I would leave it. And I would defer to Afolae for additional thoughts.
Yeah, and I would just say, we all have to really become advocates here. I mean, there was a New York Times op-ed from a New York subway driver who basically, I think the title was devastating. He said, we are not essential, we're sacrificial. And to live in a country where people feel that way, and not only feel that way, but have the evidence to back that up, means that we're all failing each other, right? So I think as numbers rise, as this pandemic continues on, we all need to be advocates for a policy that protects people that are at particular risk, and then have to go back to families, multi-generational homes, you know, places where they can't necessarily isolate from their kids, and find places that, you know, they're alone for a long period of time because they need to, you know, pay the bills, etc. So we really need to focus not on just on ourselves, but on our communities, because we're all kind of in this together. And until we do that, it's going to be the same kind of rigmarole. But I think there's a real opportunity here for us to reimagine just how we view this public health challenge and where we can get to on the other side.
Guys, great job. I'm going to respectfully kind of get folks back to their day jobs right now. Guys, we need your feedback. It's probably in your inbox. Hopefully you've already completed it. I see a bunch of responses already come in. We need your feedback, so please take a couple minutes to do that. Next week, Thursday, we're doing the digital divide, the next great social determinant of health. You can sign up on our website. And then, of course, October 29th, definitely join us for innovations in physician engagement and provider learning with Mary Ellen and her team. Can't wait for that as well. Harry, awesome job. Thanks so much for doing this with me. You made my life a lot easier. And I felt like Greg, Mike, I know you guys are super busy. The time you took to prep and to do this, huge kind of public service, not to mention just makes me look much smarter than I really am. So I really appreciate all the time. This will mark the end of our show. Spread the word about the podcast, everyone. Bright Spots in Healthcare. Thank you so much for taking all the time to join us.